السلام عليكم ورحمة الله وبركاته. محاضرتنا اليوم عن البوست تيرم pregnancy. Definitions. Post-term pregnancy is currently defined as pregnancy progressing to 42 weeks, that's to say 294 days of gestation or beyond from the first day of the last menstrual period in a woman with a regular 28-day cycles. Different terminologies are used generally in day-to-day practice, such as post-date, post-term, and post-maturity. Common risk factors for post-term pregnancy include nulliparity, previous post-term pregnancy, male fetuses and obesity. Genetic factors may also play a role in prolonging pregnancy, maternal obesity, white race. Parturition. Parturition is the process of giving birth. It is a complex process that involves events within the fetal brain, adrenals, placenta, amnion, and chorion. It induces changes in the maternal tissue, including the decidua, myometrium, and cervix. The theorized mechanism of parturition begins with a stimulus in the fetal brain, resulting in activation of the fetal hypothalamic pituitary axis, ACTH production, results in stimulation of the fetal adrenal. The fetal adrenal increases the production of dihydroepiandrosterone sulfate and cortisol. The presence of placental sulfatase in the placenta is required so that the placenta can convert dihydroepiandrosterone sulfate to estradiol. Estrogen is thought to be important in increasing myometrial activity, and cortisol is thought to be important in stimulating prostaglandin output in the placental tissues. Prostaglandins are important for myometrial contractility. Several disorders may result in delayed parturition and post-term pregnancy. These disorders are similar in that they are associated with low estrogen production. Etiology. The most common cause of post-term pregnancy is inaccurate pregnancy dating. When post-term pregnancy truly exists, the cause is usually unknown. There are rare causes of post-term pregnancy, which include anencephaly, which is the absence of the fetal cranium, with gross abnormalities associated with the fetal brain. The absence and abnormalities of these structures prevent the normal initiation of parturition and result in prolonged gestation. Congenital primary fetal adrenal hypoplasia has been associated with prolonged gestation. The fetal adrenal is important in the production of cortisol and androgens, which help parturition to occur. Placental sulfatase is required to convert fetal dahias to estrogen. Deficiency of placental sulfatase leads to decreased estrogen level and a subsequent delay in parturition. This is an X-linked disorder that affects male fetuses. Complications associated with post-term pregnancy: stillbirth, cesarean delivery, fetal macrosomia, meconium-stained amniotic fluid, meconium aspiration, oligohydramnios, macrosomia, shoulder dystocia, and fetal injury, cephal hematoma, fetal distress in labor, neonatal hypothermia, hypoglycemia, polycythemia, and growth restriction, neonatal acidemia, cerebral palsy, neonatal mortality. This is how the baby appears, as we said. Scaphoid abdomen, peeling of skin, crying alert baby, looking as an old man. Management. The goals of managing is to prevent the complications of post-term pregnancy and to prevent post-term pregnancy itself. Attempt to confirm the expected date as accurately as possible. Expected date of delivery based on the first trimester ultrasound is accurate within a week. Assessing any other risk factors as preeclampsia, diabetes, antepartum hemorrhage, fetal growth restriction associated with placental insufficiency. The use of antepartum testing to reduce risk of complications from expectantly managing these pregnancies. Two management strategies are commonly utilized: induction of labor and expectant management. Induction of labor. The success of labor induction is dependent on the characteristic of the cervix. A cervix is determined to be favorable by its Bishop score. A Bishop score of less than or equal to 4 is considered to be unfavorable for induction. Number 2, expectant management. Under close surveillance, this surveillance is termed antenatal testing. This generally occurs twice weekly, between 41 and 42 weeks of gestation. It can include the non-stress test, the contraction stress test, or the biophysical profile. Timing of delivery. Delivery is indicated when the risk of the fetus or the mother or both associated with continuation of pregnancy. As such, pregnant women with conditions such as diabetes or hypertension are at a high risk of maternal and fetal complications and are generally delivered by 40 weeks of gestation. In low-risk women, induction of labor may be performed at 41 weeks if the cervix is favorable, and if the cervix is unfavorable, then expectant management with antepartum fetal surveillance should be continued. Any abnormal antenatal testing should lead to an intervention that either provides surveillance or proceed toward delivery. Provide reassurance or proceed toward delivery. Generally, at 42 weeks of gestation, if the cervix remains unfavorable, prostaglandins are administered to ripen the cervix for induction. Intrapartum management includes continuous electronic fetal heart rate monitoring. Now we'll talk about another subject, which is fetal death. Fetal death means death prior to complete expulsion or extraction from the mother of the product of a human conception when it occurs after 20 weeks of gestation and or weight equal or more than 500 grams. Causes of stillbirths. Obstetrical complications as abruption, multifetal gestation, rupture preterm membranes. Number 2, placental abnormalities as uteroplacental insufficiency, maternal vascular disorders. Number 3, fetal malformations as major structural abnormalities and or genetic abnormalities. 4, infection involving the fetus or placenta. 5. Umbilical cord abnormalities as prolapse, structure, thrombosis. 6. Hypertensive disorder, preeclampsia, chronic hypertension. 7. Medical complications as diabetes, antiphospholipid antibody syndrome. 8. Undetermined. Risk factors for fetal death. Factors that have been associated with an increased risk of antepartum stillbirth include advanced maternal age, African American race, smoking, illicit drug use, maternal medical diseases such as overt diabetes or chronic hypertension, assisted reproductive technology, nulliparity, obesity, previous adverse pregnancy outcome such as prior preterm birth or growth-restricted newborn. Evaluation of the stillborn. Determining the causes of fetal death aids maternal psychological adaptation to a significant loss. Permit more accurate counseling regarding recurrence risk and may promote therapy or intervention to prevent a similar outcome in the next pregnancy. Clinical examination. Important tests is stillbirth evaluation are neonatal autopsy and karyotyping and examination of the placenta, cord, and membranes is recommended at delivery with careful documentation in the medical record. The details of relevant perinatal event should be provided. Photographs should be taken whenever possible, and a full radiograph of the fetus, fetogram, may be performed. Magnetic resonance imaging and sonography may be especially important in providing anatomical information if parents decline a full autopsy. Laboratory evaluation. Full blood count for anemia and leukocytosis, clotting screen for disseminated intravascular coagulation, Cly-Hour test for feto-maternal transfusion, virology infection screen for cytomegalovirus, parvovirus, autoantibody screen, anticardiolipine, lupus anticoagulant, antiphospholipid syndrome, systemic lupus erythematosus, blood and placental culture, infections such as Listeria monocytogenes, antibodies in rhesus-negative women, hemolytic disease, toxoplasma, antibodies as toxoplasmosis, skin biopsy, cardiac blood, placental biopsy, full chromosomal analysis, full body X-ray or MRI to identify congenital defects. Psychological aspect. Fetal death is psychologically traumatic for the woman and her family. Further stress results from an interval of more than 24 hours between the diagnosis of fetal death and the induction of labor. The woman experiencing a stillbirth or even an early miscarriage is at an increased risk of postpartum depression and should be closely monitored. Disease and other significant life events increase the risk for another subsequent stillborn.